Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, and we're excited to bring you the fourth episode in our GCA Fireside Chat series, where clinical insights meet candid discussions around the evolving management of giant cell arteritis. Today's episode takes a forward-looking view into one of the newest additions to our treatment toolkit. With emerging data from studies like SELECT-GCA, JAK inhibitors are gaining attention as a potential therapeutic option for patients with GCA. But what does that actually look like in practice? We'll explore the potential role of JAK inhibition, how to identify appropriate patients, what to consider when initiating therapy, and how to navigate monitoring the safety concerns in the real world. Joining me today are Naomi Amudala, nurse practitioner, and Jessica Farrell, PharmD, who are here to unpack the evidence and offer practical perspectives. Naomi, you are a fixture in this series, and our listeners know you well. But Jessica, would you mind giving us an introduction for our listeners?
Sure. Thanks for having me. My name is Jessica Farrell. I'm a clinical pharmacist at Albany Medical Center, Division of Rheumatology, and faculty at Albany College of Pharmacy and Health Sciences. I've been practicing in rheumatology for 16 years now. I was previously in a private practice, and now I'm with Albany Med, which is a large academic center. We have a specialty pharmacy. So I will hopefully be able to bring both perspectives of community practice and academic practice to our discussion today.
Awesome. Well, and you have such great knowledge. And obviously, Naomi and I both utilize your knowledge on a regular basis. And I wish that there were clinical PharmDs in every rheumatology practice because it would certainly make our lives much easier. But anyways, let's dive right into some of these questions. So specifically, let's start with the role of JAK inhibition in GCA treatment. So in our last episode, we took a deep dive into the SELECT-GCA study. And now that we've explored that data, Jessica, what do you see as the potential role of JAK inhibition in the current and future treatment landscape of GCA?
Well, I do think it's amazing that we have another option. When I first started in practice, it was really just prednisone. So we were using maybe tocilizumab off-label, and it was really fun to see, one drug get approved. Now having two drugs FDA approved is just great. I do think that our IL-6 inhibition will still kind of be first line. To help with our prednisone tapers and get patients off steroids quicker. But in patients that can't be on IL-6 inhibition, I think that JAKs are a great option. I've had a couple of patients who have had history of diverticulitis or previous GI issues, potential concern for GI perforation. So that being kind of a warning with our IL-6 inhibitors, that's something that we think about. So I think that having JAKs as an option, as an alternative is great. Also, if patients have issues with injections or infusions and don't want to do injections, I think that having the oral option obviously is a huge, huge benefit too.
Naomi, do you have anything else to add?
No, I agree. I think each class comes with its own kind of unique safety challenges and monitoring parameters that we need to be mindful of. And I think each class of drugs has a special niche population for, which patient that's really appropriate for. And I think we know every GCA patient is different and one size does not fit all. And for the longest time, I think we've been trying to kind of pigeonhole our patients into a box where IL-6 inhibition is appropriate or methotrexate is appropriate. So anything that we have that offers more options for our patients is a win in my mind.
Absolutely. And to have a pill option, like a daily pill where they don't have to come in and do the infusion or potentially, inject themselves, I think is a pretty awesome addition to our arsenal for this disease. But let's kind of shift a little bit into more of the logistical considerations. Naomi, I'm going to ask you this question first, but what do you consider when incorporating JAK inhibition into the actual clinical practice for GCA?
Well, Logistically, it's an interesting question. I think there's the problem of time. None of us have enough time. And anytime you're introducing a new drug into the practice and into your discussion with a patient, that takes a lot of time to do and to go over with them and to review. To be fair, they really should have all the options reviewed with them, and then to go through each one, and then to talk about side effects and monitoring and, what you need to do up front to get ready to be on that drug. That really does take a lot of time, and to make sure that you're educating the patient on a level that they understand. And we don't always have that time. I think it depends how much, each appointment you get with the patient. But sometimes I feel very pressed for time. And so I logistically and on a very practical level, that is something to consider. I do think also insurance companies are adapting and changing their guidelines. And their first impulse is to deny, right, medications, especially new medications. And so having the bandwidth or a clinical pharmacist on staff that can help navigate that, because I think, especially like as a clinician and somebody who's very patient forward facing, it can be very overwhelming to be dealing with the lab abnormalities and then drug denials. And sometimes it's easy to just say, okay, we're just going to give methotrexate, rather than really pushing through for what is the best option for the patient. I know, Jess, that you've had experience in your clinic in challenges trying to get drugs approved for your patients.
Yeah. So there's quite a few logistical, barriers that we have to kind of get past. So I think one thing to think about is when a drug gets a new indication or new approval, the insurance companies absolutely don't just add it right onto their formulary. There's a delay in terms of them kind of putting it into place on their formulary and what's called, step therapy. So one of the things that I recently ran into was that because the prescribing information for JAK inhibitors lists that TNF inhibitors have to be a failure or the contraindication for all of the other indications for JAKs, like rheumatoid arthritis, psoriatic, so on. The first area that I experienced in trying to get a JAK inhibitor for GCA was that they wanted them to fail a TNF inhibitor. So the insurance came back and was like, well, actually, first they said it was an off-label use. So we appealed that, which was not true. And then they want us to fail a TNF inhibitor, which doesn't make any sense because TNF inhibitors don't have a role in GCA. So then we have to appeal that. So it's a matter of the insurance company's algorithms for step therapy and their formulary getting kind of up to speed. And that doesn't happen quickly. So, even though upadacitinib was approved for GCA in, I think, April, here we are in July and the insurance is a barrier. So I'm confident that we'll be able to get it approved, but that is one hurdle. The other hurdle that I'm anticipating, which is across the board for all of our specialty medications, is cost for our Medicare population. So, with the change with Medicare this year, so in 2025, the deductible and the donut hole went away, the deductible dropped, and patients have a $2,000 deductible. And they can spread that out over the course of the year. Some choose to, some hear that number and are really overwhelmed. So in some scenarios, if they haven't met that deductible yet, so we're kind of like halfway through the year, costs might be an issue until they meet that deductible. Unfortunately, our copay assistant cards don't work for our Medicare population, and we're thinking about GCA. Pretty much all of them are going to be on Medicare. So whether this financial assistance or free drug programs, hopefully that is an option for the patients too that have trouble with affordability. But I think it really just depends on the patient from, patient's living scenario and cost of living scenario, whether they can afford that or not. The other logistical thing, which I'm interested to kind of hear your perspective, Naomi, is related to safety. So we try to, for all of our other disease states, we try to think about vaccinations for specifically zoster prior to starting JAK inhibitors. So logistically, for like our RA patients, that's not really a major issue because we can vaccinate them. It's a non-live vaccine. We can do it regardless to, what therapy they're on. We don't have to time their DMARD around it, their biologic around it, really, in most scenarios. But in our GCA patients, so they're presenting fairly acutely and on high doses of steroids. So if they're not vaccinated yet, really, especially if they're on, which most of them will be on much higher doses than 20 milligrams, we really need to wait so that they can get a robust vaccine response. So I don't know, do you have any thoughts about that?
No, I think that's a really good point. And it's funny you mentioned that because that's something that we have tried so hard to set up in our clinic is some sort of a vaccine clinic so that if a patient comes in and we know we're about to start them on a JAK inhibitor. Hey, we have the shingles vaccine and we can get you your first dose today. It's just proven to be very difficult with insurance coverage and storage and just the logistics, but that would be ideal state. And I think you bring up a really good point about the prednisone and starting a JAK inhibitor at the same time while trying to get a vaccine on board. And, in my experience, what we do is it's not ideal. I think we just give them the vaccine when we have that opportunity, even though that's not ideal. And I think there's some question of how much of a response they can mount when you're on high doses of prednisone, but it's better than nothing. And I don't really see any other alternative. There's no other workflow in my mind that can really work ideally.
Yeah, no, it's a challenge for sure.
Absolutely. Well, and obviously there are these logistical challenges, and I would even consider that to be one, just in terms of like, can we get them vaccinated? But let's say we decide that this is the appropriate option. Naomi, you have a patient that you determine that a JAK inhibitor is the correct way to go. What are you doing baseline? I mean, obviously, again, one of those things is potentially, updating vaccination status. But what other evaluations are you doing that you feel like are essential before starting that?
Well, I think taking a good cardiac history is important. And if they have any past medical history of clots or significant cardiovascular events, then we might reconsider starting them on a JAK inhibitor. From a lab monitoring perspective, I always get baseline CBC, comprehensive metabolic panel, hepatitis serologies, quantiferon, just establishing basic labs. And then I typically check labs again in 2 weeks. And then if those are stable, maybe I go to once a month. And then if it's stable for a while, then I go to every other month or so.
Jessica, is that what you're doing in your practice as well?
Yeah. And one thing I want to mention about labs is that, so on IL-6 inhibition, I've had a handful of patients that will have some anemias. Particularly, I think of one GCA patient who he kept developing thrombocytopenia on IL-6 and it would rebound and we would try to reduce the dose. But he also had like questionable extracranial GCA. So we really didn't want to stop the IL-6 altogether. So he would be a great candidate to transition to a JAK inhibitor. And I don't have a sense that, my patients on IL-6s who develop anemias, that would predict then developing anemia on a JAK. The patients that I've seen that have had anemias really haven't, there's not like a rhyme or reason to it. I haven't been able to identify any major risk factors. And that's why I think how it's so important that we are monitoring the labs so closely, especially early on in therapy, just to catch any of those. Liver and dun elevations sometimes are, a concern, but I always talk to patients about lifestyle. So if they are a drinker, that might be a risk factor for them to develop liver enzyme elevations. So I think those are things. And I think that any potential risk factors would guide our frequency of lab monitoring. So
definitely.
Yeah, I do the same. I'm not quite as aggressive with the lab monitoring. I usually start it and then, I do a same thing, all the same baselines, the lipids, all that kind of stuff. And then I usually will recheck it in like, I don't know, 6 weeks or something after they start. But just goes to show we all do things a little bit differently. But again, I think neither is right or wrong. I think it's just what our comfort level is probably. And also the patient, to your point, Jess, if I have a heavy drinker, but this is the best option because, we still are pretty limited in what our options are for GCA. Obviously that changes things. And to, something you've mentioned too, Naomi, is like, and Jessica, is, these people are usually started on high doses of steroids. So they really do need to be monitored a lot closer, especially up front. So I love this idea of more regular monitoring. But who's the best candidate, right? Like that's what I think my biggest question is. And I guess I'd start this with Naomi, just since you're at a vasculitis, center of excellence. Who do we put on a JAK versus, an IL-6? How are you making that determination in clinic, recognizing that it's only been like 3 months since these medicines have been approved? So what are you doing?
Well, I go back to what I said originally, whereas I think it takes time. And I think that we have to present all the options to the patient. And so that's what we typically do, unless there is some glaring contraindication to not do an IL-6 inhibitor or JAK or methotrexate. I think all options are on the table. And then it comes down to, I think, lifestyle, patient preference, and then unfortunately, the all-powerful insurance company and what they're going to cover at the end of the day. Sometimes we don't have as much control over those medication options as we think we do. But in my mind, it really is kind of that shared decision-making process with the patient, them being aware of the risks and benefits of each medication, and walking them through that, and then letting them make the decision and us guiding them as clinicians.
Absolutely. Jess, who should we avoid giving JAK inhibitors to?
Yeah, well, I would definitely say if someone had, a recent cardiac event, so a THOTS or an MI, those are patients that JAK aren't, still questioned out there. With upadacitinib, the safety looks good in the clinical trial. There were patients with cardiovascular risk factors that were included in the SELECT-GCA study, so that's helpful. But long term, big population data on safety from a cardiovascular perspective, it still kind of is in the back of your head, where an IL-6 might be a better option. If a patient does have, risks for shingles, it hasn't been vaccinated, risk, we're giving them lots of prednisone. So, it's there. That one's a tough one to really say, like, what, can you predict if a patient is going to have a zoster outbreak? Those are kind of the big ones I would say. I think one of the most important things that, as a pharmacist on this podcast, I will say that documentation for insurance coverage is so important. So everyone, make sure you are including, because I guarantee that the insurances are going to want to know, why don't you want to use the IL-6, or why can't you use methotrexate? So when you're writing your notes, as Naomi said, it's so important that it's shared decision making with the patient, but from your perspective, is one safer than the other? And having that in your note just makes the insurance approval process so much easier. Yeah.
That's a great tip. Thank you.
Yes. Something I traditionally was not great at. I've gotten better over the years, and my medical assistant is always like, make sure you put tried and failed in every single thing, but not just tried and failed, like the actual dates and all of those things, because I will say that it's getting harder and harder to prescribe, these medications for patients, at least in my experience. I am finding that I'm having to do more and more peer-to-peers, and which, again, to your point, Naomi, we only have so much time. And, then to spend additional time outside of clinic doing that can be certainly challenging. Um, Let's talk just a little bit about the global impact. I guess this is my last question. So obviously we know this is a great additional option, but now we have upadacitinib approved for GCA. And what is this going to look like? I mean, in terms of thinking about it from a global perspective, adding this to our arsenal of medications. Naomi, I'll start with you.
I think in the United States, we're fortunate to have access to all these medications. We do have insurance kind of dictating to some degree, but at the end of the day, I think hopefully if we can make a reasonable argument for why a patient should be on a certain drug, we can get it. I know that that's not always the case in other countries. Unfortunately, prednisone is always available. It's cheap. I think it's available in every country. So that's always going to be an option, especially for people who don't have access to JAK inhibitors and things like that. But hopefully it'll have a global impact in that it's going to be readily available to people with giant cell arteritis, no matter where they are.
Jessica?
Yeah, I think one of the things we didn't really highlight is how bad prednisone is. So we didn't really talk about how awful it is. And then when we think about a GCA population, when I think about prednisone, in clinic, I have pharmacy residents that spend time with me, and they're in family medicine also. So they give me this perspective of the diabetic patient. And, now also with our patients that are diabetic and wear continuous glucose monitors, we can see so much easier how bad prednisone is for their sugar levels and complications associated with their diabetes. So GCA is affecting an older population. Many of them may have diabetes. Prednisone is just so bad for them. And if you look also from the safety perspective of infections, the prednisone and placebo group in most of these trials has more infections than our, biologic or targeted synthetic like our JAKs. So I think that is something that changing the culture of using prednisone and starting steroid-sparing therapies just so much quicker and as soon as possible if insurance isn't a barrier. I think it's just really important, and it highlights that in these studies that look at prednisone alone, I think just highlight that even more. So I think that's one of the things I think about is just let's use less prednisone.
I was doing a podcast with, I think it was Claudia, and she called prednisone the devil's candy. And I thought, I've actually used that now a few times with patients. I'm like, and if you think about it, it kind of is, it's obviously life-saving and such an amazing drug that saves people's lives, but there are so many risks associated with it. So how incredible that we have other options where we are able to give people off steroids pretty fast once they're on an IL-6 or a JAK inhibitor.
Mm-hmm. And I think that, having an option for patients that don't do well on an IL-6 inhibitor, I think there were a subset of failures in the SELECT-GCA study. So we don't have a ton of data to say all patients who fail, IL-6 inhibition are going to respond adequately to a JAK inhibitor. But that's certainly the population that will start using it in, I would think. And that's kind of where I see its place to be used initially. So I think that will be interesting to see what that data shows us in those difficult to treat patients.
Absolutely. Well, thank you both so much. I always learn so much from both of you, and I feel so fortunate that, I have your cell phones that I can reach out to you all the time to ask my challenging questions to. And again, for all of our listeners, I'm happy to share their cell phones. So if you have my information, I will share theirs. So don't worry about that. Or come to the RhAPP conference and I'll give it to you there. So that's in September in Denver. But with that brings us this episode to a close. So again, thank you so much, Jess and Naomi, for sharing your expert insights into JAK inhibition and the role of GCA treatment. We sure hope that this conversation gave you a clear view on how to approach this emerging therapy from both identifying the right patients, and I would also say who might not be the right patients for this, and really understanding the safety considerations in clinical practice. Please be sure to join us for our final episode in the GCA Fireside Chat series, The Safety Conversation. Upadacitinib in the treatment of GCA, where we'll focus specifically on the safety data and what that means for clinical decision-making. Thank you to AbbVie for your continued support of APP education, and thank you for listening to RhAPPcast. I'm Amanda Mixon. Until next time.